Welcome, everyone. Thank you for joining us this evening. It's evening for us in Boston, but obviously there's a number of people joining us from around the world. So wherever you are, good morning, good afternoon, good evening. Thanks for joining us. This is a part of a series of training webinars that we're doing with Dr. Robert Kirstein and Dr. Ben Sutter. This one is focused on understanding the TScan graph. So although this is applicable to any dentist that's out there, whether you are a person that's currently using TScan in your practice or someone that's not using TScan in your practice, certainly some of the concepts that are introduced tonight, if you're not currently using TScan in your practice, you may not be familiar with the graph, but we can always get you up to speed. And tonight we've got, I'll be here. I'm Jen Cullen. I'm the Director of Healthcare Sales here at TechScan. We've got Justin Hysenius with us as well.
Good evening, everyone.
And of course, we've got Dr. Robert Kirstein, and Dr. Kirstein doesn't need much introduction to us. He's been a longtime dental consultant for TechScan. He's the leading expert on the TScan technology in the world, and just an unbelievable resource for all of us that are here at the company, but also around the world teaching concepts of digital occlusion. So thank you so much, Dr. K, for joining us tonight.
Thank you.
Yeah, of course. So I know you've got some stuff lined up that you want to share with everybody. So what we'll do is we've got about 45 minutes of presentation, and then we'll do some question and answers. Justin will answer your questions. You can either type those, you can either chat with Justin directly, or you can put those into the Q&A section of Zoom webinar. We are recording this webinar, and we will be able to send the webinar afterwards as well. So, if you don't feel like taking notes, we will send you the webinar after. So without further ado, Dr. Kirstein, thanks so much.
Thank you. And thank you, everyone, for attending. I know it's difficult to come sometimes after work for a nighttime presentation, or if you're waking up early in the morning in some part of the world. We are grateful for your attendance and appreciate your interest in learning more about the TScan. This session is really about the force versus time graph, and that's a very important TScan topic. So I'm going to go right into it so that you can get a feel for it. And let me just put on the slideshow. There we go. Okay, so understanding the TScan force versus time graph, which is what you see here that my mouse is pointing out. To an untrained eye, it's a complicated series of colored lines, but to a trained eye and to a TScan user, it's one of the most important software features that you have to learn to understand. And actually, it's a skill that helps you become a better and better TScan user. So hopefully by the end of this session, you'll all have a good handle on what all these colored lines mean and what they're actually telling you. And the goal is actually to be able to read the graph without playing the TScan data. So if we've succeeded in educating you, you'll have a better handle on all of that when we're done. I am a little bit about me. I've been using the TScan since 1984. I began working with it as a graduate student, as a prosthodontic resident, and I've written over 100 peer-reviewed articles on the TScan, as well as textbook chapters. And my role with TechScan is education, research, and training. I am a consultant for TechScan. I have been since 1997. I do not receive compensation for sales of any TechScan products, and the opinions expressed tonight are mine and not necessarily those of TechScan. If you're interested in learning more about the TScan after tonight's seminar, these 5 volumes have a tremendous amount of information in them about all aspects of TScan, not only the force versus time graph, but TScan in orthodontics, TScan in prosthodontics, TScan in implants, TScan in general occlusion, TScan in TMD. And these are available from the publisher IGI Global, and they would really help anyone who's interested in learning a specific TScan discipline. Okay, the force versus time graph. As I said earlier, it's one of the most important TScan user skills to master. And to reiterate, you want to learn as a TScan user to read the graph without playing the movie. So in other words, you'd be looking at this and you would understand what it all means. And of course, if you don't have a TScan, that's you may not even have an understanding of what this all means in any way, but those of you who have a TScan may not actually be using this software feature to the level that you should be. And so the goal of today's webinar is to help you get there and to be able to read the graph without playing the movie. It's very important that you understand obtaining high quality diagnostic TScan graphs depends on two things. It depends on your ability to record patient functional movements, which is a skill in itself that involves coaching the patient, that involves viewing the screen, that involves observing the data as it's being recorded live. And the second, and even if not more important, is choosing the right level of recording sensitivity, because the recording sensitivity dramatically influences the graph. And recording sensitivity, for those of you who have a TScan, is the amount of electricity that runs through the sensor. It's much better if you work with lower sensitivities. You want the patient to have to work a little against the sensor, and that's where you have less electricity in the sensor. And that when you have the patient work against the sensor, you get to see if they have a dysfunctional bite, which you'll see in many examples in this session. If you have too high a sensitivity, there's too much pink on the screen, and that washes out the dysfunction because the sensor is too responsive to the patient. And so when you have too much pink, not only do you remove the dysfunction, but you also falsely improve the occlusal balance. So the more active the sensor it is, the easier it is to balance to get closer to 50-50. And these are all false representations because the sensor is acting too easily in response to the patient biting. So the ideal sensitivity to get optimal graphs is 1 to 3 pink sense cells, which I'll show you in a second. And ideally 1 at the maximum amount of total force is perfect sensitivity. But from 1 to 3 is matched to your patient's bite strength, is going to give you the correct outcome. Here's an example of very high sensitivity. There's actually 9 or 10 pinks, and when you look at them, they're all distributed around the arch. And then if you come over here, you'll see the balance is 51 to 49. That's actually not true balance, because you only want to have a few pinks, which are, pink is an unknown amount of high force. So here's the force scale: low force, moderate force, high force, and then unknown. The more unknown there is, the more active the sensor is. So this balance of 51 to 49 is not accurate. There's too many pinks. And here's an example of what I mean by too many pinks. This recording has 14 pinks in it. And if you look at the graph lines, I'm going to explain in detail, but the black line is total force. And that's the one that you can see the patient's dysfunction in. So here you see the patient is biting down, their forces are going up. They hold their bite in MIP very well. That's what this horizontal period is. You don't see any wavering in the black line. The red line and the green line are the right half of the arch and the left half of the arch, and they are very flat and horizontal. Because the sensor is so active, it's very easy for the patient to bite into it and create data that is basically taking out all the dysfunction. And you can see the balance is off by 5%, despite them missing some teeth. Now, if we use the same patient and we correct the sensitivity to where there's only 2 pinks, look at the balance now. It's 21 to 78. Right? And look at the graph lines. They're not perfect anymore. There's a lot of wobbling in the patient's ability to close. They struggle to bite down. They slow down here. They squeeze. When they squeeze, they waver. Their mandible is wavering. And the sensor can pick that up, but only if the right amount of pink is on the screen. So this is the same patient you just saw, 55-45, and yet it's actually 78-21 when you record at the correct level. So again, to reiterate, high sensitivity falsely creates balance. Here you see the red and green lines are very close together, only 5% differential, and it washes out the dysfunction. The correct amount of high sensitivity, only 1 or 2 pinks, you see this patient struggling to bite down in both bites they make. This is bite 1, they're slow to close, they squeeze hard, they slow down, they get to near maximum force, they have to squeeze to get to maximum force, the mandible's wavering. And you see the same in the second bite. They struggle to close. It's not a perfect straight line. Compare it to this one, how much easier it is, right? This is the one you want to work with. So let me show you sensitivity control on the TScan. Let me stop my share, and then we'll go back into the PowerPoint in a second. Okay, so I'm going to share my TScan now. So the sensitivity scale is here on the bottom. And just to give you an idea of what happens when you have very high sensitivity is I'm going to bite into the sensor. And you can see all this pink. That's a useless recording. You really want to work on the bottom half of the scale. This is where you want the sensitivity to be. You might come up to the middle, but it's better to make your patient bite hard than it is to have the sensitivity way up. It's a big error to have the sensitivity way up. So here I'm going to bite with this much lower sensitivity. And you see I gave 5 pinks. So I could actually come down maybe to the bottom one. And this is what you actually do. You calibrate the patient before you start recording. So with one pink, with one block of electricity in the sensor, that's ideal sensitivity. Okay, go back to the PowerPoint. Stop this share. Okay. Now there are 3 types of graphs. Closure graphs, which are usually a multi-bite or a single bite. That's the one I just showed you, the two bites with the patient struggling. Then there's excursive graphs, which are different than closure graphs in form, right, left, and protrusive, although they contain the same biting down element. All the TScan recordings, you want the patient to bite, hold, and then either open or bite, hold, and slide. And the third type of graphs are tooth selection graphs, where you can look at force outliers, which are very fast rising teeth that have too much force on them, and tooth timing, which I'll show you an example of how you use tooth timing with implants.
So Dr. K, we can't see your screen.
Oh, you know why? Because I didn't push the screen. Thank you for telling me. I apologize. Let me go back to the Zoom. Let's see, there's the share screen. Because I didn't go back to the PowerPoint. I apologize.
It's okay.
Thank you for telling me. Now you should be able to see it. Yes, okay.
Yeah.
Okay, so the types of graphs, let me do this again from the current slide. That's good. Closure graphs, excursive graphs, and tooth selection graphs. And I'll show you examples of each of them and teach you about each of them. And I apologize for not screen sharing. Wait. This is a multi-bite closure graph. Closure graphs involve the patient biting down, remember the black line is total force, and we'll go into the lines in detail, and holding their teeth together in MIP and then opening. And then they do the same thing again. And in this case, the person did it 4 times. And you can see consistency in the closure graph. And the reason it's only a closure graph is the patient bites, holds, and opens. That's all they do. And this is an important graph. It's used to balance the bite. If I want to balance someone's bite, I'm going to work between A and B. And we'll talk about that. I'll show you an example of that. But basically, the A to B segment is used to balance the bite. And A is first contact, B is static intercuspation, which I'll explain in a minute. So in a multi-bite graph, you have these repeated closures, and you see the red line is consistently above the green line in this person's case, which means that they have more force in the right half of their arch than their left half of their arch. And this is a very consistent patient, although there is some dysfunction. You can see there's some sort of wavering in the black line when they try to hold their teeth together, so they are struggling to do it. And that's important. You want to be able to see dysfunction in the black line. What does the different colors illustrate? Let me move this out of the way if I can. The colored lines. The black line is total force in all graphs. So in a closure graph, the patient bites down. Here they're actually slowing down. Here their forces are going up. Now the forces are slowing down. Here they reach static intercuspation. That's where the B line goes. We'll talk about that in a second. Static intercuspation is where the forces rise quickly, but then they slow down. And that leads to maximum intercuspation, where the person squeezes to full contact. So the black line is total force. The red line describes the right half of the arch. So you can see here, the right half of the arch, the force percentage is very low. The green line represents the left half of the arch, which is in this case very high. There's a huge right to left imbalance in this case. And the graph illustrates that, again, without playing the movie. And the distance between the red and green lines describes that balance. Okay, so those are the colored lines in a closure graph. Now the vertical timelines, they're very important lines, and they're movable lines that you actually control. A1 is first contact. That's where the bite begins to rise in force. B is static intercuspation. As I said before, static intercuspation is where the bite forces rise and then begin to slow down. And that's what goes on in every closure. The patient's teeth bang into each other, the teeth fit together, they all come together, and suddenly the forces slow down, and then the person squeezes to full contact. So static intercuspation is a really important place to recognize. Maximum intercuspation is not as useful from treating someone as is static intercuspation, because that's more functional. Nobody bites down maximally and does anything. Nobody bites down hard to the maximum force and chews. You bite down 70, 80% of your full capability. The C line is when the person opens. So here, the black line, the patient bites down. Here they slow down, but they're still rising in force. Here they're holding their teeth together. They're wavering a little. And here they open. And so at C, forces drop dramatically. And then at D, there are no more contacts in a closure graph. The A to B time is called the occlusion time. The C to D time is called the disclusion time. And those times are captured by a timing table, which is on the TScan desktop. And when they're good times, you get a check mark. Like the A to B period is very fast. It's 11 hundredths of a second. And the C to D time, which is really the opening time, is 13 hundredths of a second. So these are very physiologic times. And although there's a huge imbalance in the bite. So the graph is illustrating that very clearly. Here's an example of someone getting weaker when they use, and you can see this in the graph. Here's the first bite they make. They bite down, they reach static intercuspation, they hold their teeth together, they open. Now the second bite down isn't as forceful. See, in the graph, they're only making it to 80% of the first bite, and in the third bite, they're actually a little bit lower, right? So this person is getting weaker as they bite. That's a sign of dysfunction. Even though they're able to bite and hold their bite together, they're still getting weaker per bite. That's a sign of dysfunction. Notice there's only one pink at full force. Full force is where B, just past B, full force might be here, but this is where you need one or two pinks as the black line turns sideways. So that's a very good example of someone getting weaker, okay? Now here's a weak patient trying to bite into the sensor, and the graph shows you their dysfunction. You can see instead of the black line rising quickly, like I'll go back one, see how fast the A-B period is. This is a very short period of time. A1, B1 is 13 hundredths of a second. That's over here in the timing table. Now look at this patient. They bite down, but they can't squeeze their teeth together. So they stop biting. Now here they squeeze together, then they lose force, then they increase force by squeezing, then they lose force, then they squeeze to get to full contact. And you can see all the wavering in the black line. So these three places with the arrow show hitches in the graph line, the total force line, that show the patient is struggling. And you see it in the second bite the same. There's a patient biting down. He's very slow to close. There's no verticalization of the total force line. It's only horizontal, which means that there is not much force going up. Then suddenly the force goes up, but then he loses force. Then she squeezes or he squeezes. Then they stop squeezing. Then they squeeze again. Then they lose force. Then they squeeze again. All of that is visible because the sensitivity is correct and the patient is struggling to bite. So you need to have a good sensitivity to get a graph line like this. Really, really important. And then the A to B time is actually much longer. And you can see that here, A1, B1 is 1.18 seconds, and it gets a stop sign because that's a bad time. Good times are very short. And again, the patient opens in a multi-bite. They open. C to D is just them opening, and those are actually very physiologic. So the A to B period is much more diagnostic for this patient. Now, one of the things that's really beautiful about the total force line and the graph is you can see functional improvements in the total force line. So here's an example of that. Here's a denture, overdentures being delivered, maxillary mandibular. This is the delivery after paper only adjusting. Now, what's interesting about this image is you see the paper on the left, there's a lot of ink on the left, right? And there's not so much ink on the right. Now, look at the data. The right side is 67%, the left side is 33%. There's a lot less ink where there's a lot more force. And that's actually fairly common. But look at the total force line. It rises, it's got a hitch there, it's got another hitch there, then there's a lot of vibrating, then the person can't hold their bite, then they open. Second one, they struggle the whole way. There's a lot of wobbling. Then we go ahead and treat that denture. We actually use the TScan to control what's happening, the earliness of all these areas, the late left side with low force, and we want to deal with all these high forces. So when we get a corrected one, Watch what happens. Things rise together. See how all the columns go up together. The center of force comes to the middle. The balance is only 4% off. Look at the total force line. It still has flaws in it, but it has less flaws in it because it's easier for the person to bite into these dentures. So the total force line can illustrate improvement as well as dysfunction. And this was all done in 1 day. So this is in a 1-day correction, dramatic improvements in this set of overdentures. Okay, excursive grafts. So excursive grafts have the same biting down part and the same holding together part, although this person is struggling to do that. But then instead of opening, they make an excursion to the left, right, or forward. And this is used to identify the anterior guidance function and prolong posterior interferences in time. The A to B period is still the closing. The C to D period becomes the disclusion time, or the time it takes to reach total posterior disclusion. These graphs are best analyzed in quadrant view, which is why you see 2 more colored lines. So I'll explain all this in detail for you. If you want to see quadrant view, there are 2 ways to do it. First, in your settings, go to your advanced tab and check off show all excursions in quadrant view. Then anytime you label a movie as a right lateral or a left lateral or protrusive, it will come out with the quadrant division already set up on your playback. The other way is on the TScan desktop is to go to the view menu and choose arch in quadrants. And that will take an arch that's divided only in half, right and left. And this is an excursive graph. The patient bites down, holds their teeth together. Here they're going to the right. And you see it looks like the right side discludes the left side. The red line rises, the green line goes to 0. But it's not in quadrants, right? So if we want to see it in quadrants, we go to the view menu, we click on arch in quadrants, and then we have the same graph. The total force line remains the same, but we have 2 new quadrants. We have a posterior right blue quadrant. So the blue line represents the forces in the posterior right quadrant, and the orange line represents the forces in the posterior left quadrant. So here, the patient's biting down, holding their teeth together. When they go to the right, the balancing side, the left side, drops out, and you see at this point in the movie where the timeline is, there's no more balancing contact. The orange line goes to 0, but the blue line shows that the posterior right quadrant remains active. And you, oops, I'm sorry, let me go back there. There we go. Goes, and it stays active for a long period of time. And the anterior guidance quadrant, which is the right anterior quadrant, whoops, sorry, the right anterior quadrant slowly takes control over the excursion. So this patient has a prominent group function, and the graph line shows you that. The blue quadrant is posterior group function. Now, what do the lines mean in an excursive graph? Very similar to the closure graph. The black line is total force. So here you see a patient struggling to bite down, then they squeeze harder, then they waver, then they let go, and here they begin an excursion. The red line now represents the anterior right quadrant. So in the closure part, the anterior right quadrant doesn't have much force, but in the excursion, it tries to work, but it can't really work because the orange and blue quadrants are very involved in this patient. The green line represents the anterior left. So again, being an anterior quadrant has less force than the posterior quadrants. And then when the excursion begins at C, the anterior left dissipates because the person goes right, away from the anterior left. The blue line, again, represents the posterior right quadrant, and you see here it's the most forceful quadrant in closure. B to C is closure. C in the excursion, you see the blue quadrant loses force, but then it gains force, and then it continues to control the excursion all the way out to here. So the posterior right is very involved in this patient's excursion to the right, and the orange quadrant, which is the balancing side, loses some force, but then gets in the way, the forces rise, and then it dissipates almost to 0, but it hangs around. So there's balancing side contact that actually worsens over time. There's working side group function that worsens over time. And then finally, right here, where the D line is at the red quadrant reaching 100%, does the anterior guidance take over. Now the timelines, the vertical lines, A, B, C, and D, they're important in an excursive graph as well. A, again, is first contact. You see the total force line rises from there. B is static intercuspation. Now, this B is not in the right place, and I'm going to explain to you why that is. It actually belongs here, where the rise in force begins to slow down. And that's important because that changes the occlusion time, which we'll show you in a second. The C line is the beginning of an excursion. You see the total force line drops. There's where the excursion begins. And the D line is where you get, it's to be placed where there's complete posterior disclusion. Well, that's where the orange line reaches 0 and the blue line reaches 0. And so D, the C to D time is the disclusion time. The other thing that's very important in this graph is steps. See these steps? That's excursive friction. That's back teeth rubbing together, clanging into each other, not freely separating. It's different than an interference. There are interferences, but there are frictional interferences that create these steps. And excursive friction is bad. It's what causes wear, abfractions. It also causes tooth mobility. It sands away tooth structure. It raises muscle activity. And the difference between the C and D lines indicates the disclusion time, which in this case is very long. The timing table, again, will reflect A1, B1. That's the closure time. But again, it's not correct in this graph. I'm going to show you that in a second. And C1, D1. C is the beginning of the excursion. D is actually in the right place. The disclusion time for this is 2.72 seconds. That's not healthy. Healthy is 0.5, 0.4. So this person has a lot of back tooth problems involved in their excursions. And the graph diagnoses that if you understand the colored lines. Now, this is an example of someone who's going to make a right excursion, but they let go of their total force. And so when they begin the excursion, which is here at C, they're only making the excursion from 60% of total force, which means a lot of the excursion is going to be missed. So this is not a good recording. You want the excursion to begin with the black line at the top of the graph. That means the person is fully intercuspated. So this is a person who's weakening. That's a sign of dysfunction. They can't hold their teeth together. They max out their bite and then they lose force. So their teeth are coming apart. Here's an example of a patient struggling to close. They stop. Here, the graph, the black line is horizontal. They stop. They squeeze again, they stop, they squeeze again and stop. Anytime you have a horizontal line, the people are stopping from moving. And then you see how many times it took her to close to get to full contact. And then you see all this excursive friction, all these steps. So this person doesn't disclude well and has most likely muscle tension issues or recession and abfraction mobility. Now, setting the lines is a user skill. So I'm going to use this graph as an example of how to properly set the lines. So I'm going to leave the TScan, I'm going to leave the PowerPoint and go back into the TScan, which is here. Okay, good. And you guys should be able to see my TScan, which is there. Okay, good. So let's go up to this movie. So this is the graph of the patient you just saw, but it's in 2 quadrants, right? So let's do all the steps. First step is to view it in quadrants. So I'm going to go to the view menu, put the arch in quadrants on. But the arch in quadrants line isn't in the right place. It came on in the premolars. We want to move it to the working side anterior guidance quadrant, which is, in this case, is the right anterior quadrant. So I'm going to drag it up and set it between 6 and 5 data. And that's going to change the graph. That actually, I'll show you drastically. I'm going to pull it way down and see what happens. Now look at the graph over here. And you'll see all the lines will become very different because we just made a red anterior quadrant very big, right? So now it has much different force profile. So I'm going to move it back up to where it belongs. And you'll see the graph lines will change again. Okay, now we have the accurate division of the anterior guidance, the posterior group function, the balancing side, the non-working anterior guidance. So where do we set the timelines? And the importance of this is that where we set the timelines is going to be reflected in the timing table, which judges the physiology of the patient's capability. Well, the B line belongs here. Remember I said it belongs where the static intercuspation slows down, right? That's where she's biting down, forces are rising, now she's stopped, right? And then she can squeeze another 10% to full contact. So the A to B time is now much longer, 9/10 of a second, not healthy. And that's reflected in the horizontal nature of this line. The C line belongs where the excursion begins, and that's where the black line begins to drop. And in here, the patient is holding her teeth together. So if we just play the movie, if I just drag, I'm going to actually drag because it's faster than playing. You see, I'm dragging, the patient's holding their teeth together. Nothing is really changing. They're losing force. But when they actually go into their excursion, you'll see the center of force this diamond will start to move. And you'll see that's going to come now. See, that's where the center of force starts to move. Now, it's not moving towards the right anterior quadrant. It's actually moving left. This is the left side. It should be moving that way, right? So the C line is going to move to here, where the black line begins to drop. And the D line, if you remember the definition, is where both posterior quadrants reach 0% force. There's total posterior disclusion bilaterally. So that occurs here, where the blue quadrant reaches 0 and where the orange quadrant reaches 0. And if that's hard to see, here's another feature. You can click on this and you can actually make a little bit of a zoom window. Whoops, see if I can do that. Try that again. That won't let me do it at the edge of the graph. Let me try it a little closer. This is an important feature also, so I want to show you. See, now it blows it up. It actually blew it up too small. Let me see. Let's see if I can do that. We're going to keep it the way it is. I'll come back to that. So D is where the orange reaches 0 and the blue reaches 0. That wasn't helpful, so I apologize to that. I'll have to show you another reason to blow up the graph. So the D line goes here, and what you'll see is the time changes. The distance between C and D changes. So if I put it over here, the C to D goes down. You always want to put it accurately where it belongs, because then you have a true reflection of the actual disclusion time. So that's how we would set the lines. The B line had to move to here, the C line had to move to here, and the D line had to move to here. To show you the zoom graph blow up, I'll just do this. I'll show you the beginning of the excursion so you'll be able to see. Okay, so now you can see the blue quadrant is active, the orange quadrant is active, the total force line has steps in it from friction. And if you want to reverse the zoom, you just click on this. Okay. Now let's go back to the PowerPoint. Let me share the PowerPoint, which is here. Okay. Okay. So let's use the force versus time graph to diagnose a patient instead of playing the movies, right? So here's a patient that's class 1 post-orthodontic. They have lots of abfractions on all their posterior teeth. They have reasonable anterior overlap. They look like they have good interdigitation. They're a clencher and a grinder. They have frequent headaches. They have jaw pain, and they have a minor occlusal wear, but they're definitely losing root structure. So if we look at their TScan data, so we'll leave, let me stop this share. We'll go back to the TScan. If we look at their TScan data, here's her multi-bite. So if we look at the multi-bite graph without playing the movie, you can see here she made a strong closure, but the second closure she's weaker and she loses force. The third closure is weaker, she loses more force, right? So she gets weaker as she bites. That's a sign of dysfunction. That would be a reflection of her muscle physiology. She's only 8% imbalanced. She has a lot of posterior tooth contact, not much anterior tooth contact. That's a common look for a dysfunctional patient. So the closure graph illustrates the beginnings of dysfunction. The right lateral graph, here's the closure piece. She bites down, she wavers, right? She holds her teeth together pretty well, and she begins her excursion. Well, what do you see? Excursive friction, steps. The blue quadrant, very active. The anterior guidance quadrant doesn't really work until very late in the excursion, and the balancing side is also involved. That's the orange quadrant. So this person has both balancing and working interferences, and you'll see when I drag through, right, that the center of force doesn't go to the anterior right. It's actually fighting between going right and left, and finally it goes towards the premolar, where she has premolar guidance. And the disclusion time is 2.11 seconds because the C line is in the right place and the D line is in the right place. The red line reaches the top of the graph, the blue line reaches 0 there, the orange line reaches 0 here. If I go a little further, the balancing side will disclude. There's the balancing side discluding, but the working side isn't discluding yet. That's why the blue quadrant is still active. So this graph clearly shows that she doesn't disclude well, and that would explain why she has recession and abfraction, mobility, wear, and clenches and grinds. The left the left excursion, the same. She's able to bite down. She struggles a little to hold her teeth together, But when she goes into her excursion, there's again excursive friction. And again, the balancing side in this case is the blue quadrant, and the working side is the orange quadrant. Both are active as she moves to the side. And her disclusion time is very long. Both movements are very long, 2 seconds each one, right? So that's a marker for high muscle firing, wear and tear on the teeth. You see the center of force can't go towards the anterior left quadrant. It's trying to, but it struggles between the balancing side and the working side remaining molars, right? So this is very dysfunctional graph that clearly shows that she doesn't disclude well. Then we treated her, and this is the same day. You can see the dates are the same. Now this is an hour later, the left excursion. Now you see a different pattern. Well, first, the patient doesn't really struggle to hold their teeth together, so they're already responding physiologically. The total force black line drops. There's still some friction in there. You can see subtle friction. It's a lot less. The anterior guidance green line rises immediately, and the blue and the orange quadrants dissipate very quickly, giving us a disclusion time of 0.3 of a second. So this is a much more physiologic movement, and you'll see the center of force will head right towards the anterior guidance. Right, there you see, right towards the anterior guidance. So by treating the disclusion time, we improved not only the physiology, but we improved the graph lines to show progress, occlusal progress. Same thing in the right lateral. Here you see again, the patient bites down, is able to hold their teeth together. They go to the right, the blue and the orange quadrants drop, the red line takes over right away. That means the anterior guidance takes over right away, and you'll see the center of force heads right to the canine. All right, so that's all through corrective control, all done in one day. And you can see the disclusion time in the right excursion is very good at 0.3 of a second. The occlusion time is a little slow, and you can see why. There's a horizontal period, then there's a sharp rise, then there's a slowdown, right? So the closing is still not as good as it could be, which again can be diagnosed from the graph because of the shape of the black line. And the excursive part is very good, big improvements. Okay. Let's go back to the PowerPoint. So you look at the comparison with the right excursive graphs, right? Because that's really what we're teaching you is about the graphs. You see preoperatively, there's a struggle to hold the bite, but she does it. When she goes to the right, there's the excursive friction, the steps in the black line. The anterior guidance quadrant doesn't work. It struggles to take control. It takes a long time to get control, which is out here. And the working side group function is very prominent. That's the blue quadrant. The orange quadrant is also very prominent. That's the balancing side. And the center of force can't get to the canine, right? Now look at the after one, right? The red line rises very quickly. The blue and the orange drop very quickly. The center of force goes directly towards the canine. This is a much more physiologic outcome, all done through time-based corrections that you can see the improvements in the graph lines. That's why it's so important to get good graph forms when you're recording and to have very good sensitivity. You notice these recordings, you don't see a lot of pink, you don't see a lot of excessive data. Very important. Okay, last topic, a tooth selection graph. Very important subject. Mostly I use tooth selection when I have implants. And one of the best things you can do with implants is you can track the time that they're involved in excursions, because teeth that rub against them are maximally compressed and flexed into their PDL and the pulp flexors because these are so rigid. So they worsen muscle activity levels when there's long disclusion with implants against natural teeth. They flex teeth on their axis much more when they're against implants if there's prolonged disclusion. So this is a really good example of a place that we can use tooth timing to look at the two crowns that are on this case that are on implants. So here's a tooth, this is before tooth timing. Here's the patient's status in MIP. They're biting down, they're able to hold their teeth together, but when they go to the left, there's a very prolonged orange quadrant. And in the lower arch, you'll see the orange quadrant is here, the posterior left, right? So that's the posterior left, very involved. The anterior guidance doesn't work. Well, if I want to find out how long the implants are involved in this excursion, I can use tooth timing. So let's leave that and share the TScan once more. And what we're going to do is we're going to flip this over to the lower arch. So you'll get to see me do some manipulations of the T-scan. So view, I'm going to flip the arch horizontally because I want the left on the left. So that's going to flip that, hopefully. So it'll do it. Waiting for it to do it. Okay, and then I want to put the lower arch on. Okay, and then I'm going to come back down here to this movie right here. This is the movie that we just saw. So here's the movie you just saw in the PowerPoint. Patients biting down, holding their teeth together. They go to the left. All right, I want to find out how long these two implants are involved in the excursion. So I'm going to go to tooth selection up here, and I'm going to select 18 and 19. And what I'm going to get is a graph line of them alone. And this feature here, the sum sign, actually is a choice I have made to keep the total force line on. You can actually turn the total force line off and just get colored lines for the individual teeth. But the value of putting the total force line on is very important in this case. It shows that almost all of the force of this 76.9% left side is actually made up of that one tooth. The brown line follows the total force line almost exactly, not only in closure, but also in the excursion. Okay, so now I'm not playing the movie. I want to see how long these two teeth are involved in the excursion. So they disclude right there. The brown number 18, the brown line reaches 0 there. The purple line, which is number 19, reaches 0 there. So I'm going to move the D line back to where those are. And then I'm going to click on the timing table, which is going to tell me that the C to D time, which is where the implants are involved in this excursion, is 0.4 of a second of the excursion, which totals 0.5 of a second. So 80% of the time, the posterior left implants are involved in the excursion. And you can see that here, right? The center of force goes right over them. And it's not really until there that they begin to dissipate, right? Well, that's not good. That's where they're, even though 0.5 a second is a good parameter, we want those implants discluding in 1/10 of a second, 0.2 of a second. We don't want to see them discluding in 0.4 of a second. So we can fix that because we can measure those things with the T-scan. So here's the left lateral afterwards. Now look at a few changes after we corrected what went on. First, the closure center of force. Look at the balance. If preoperatively it's 76 to 23, postoperatively, the balance is 45 to 54. Look where the center of force is. It goes right into the middle of the case. The implants do not have implant warnings anymore. Let me show you what I mean by that. See, these implants are under overload warning. That's another great TechScan software feature, right? Now, after correcting the implants in closure and excursion, we have no more warnings, which is perfect. Now, how long are the implants involved in this excursion, the postoperative excursion, which lasts 0.14 seconds? Well, we do the same thing. We go to tooth selection. We select those two teeth. You see right here is where C is. That's where the excursion began. You see the brown line drops quickly. The purple line drops quickly. We're going to move the D line back next to them. And then we come back to the timing table. And so they disclude, instead of in 0.4 of a second, 0.42, something like, they disclude in 1/10 of a second. So 75% less are they involved in the excursion. And you can see that here as the movie drags through, they quickly dissipate and the anterior guidance takes over very quickly, right? So that's the nature of, if I played it and stopped, you'd see that. If I just go to there, right? So that's how you use tooth timing. And that's a really great feature when there are implants involved. You can time the closure, you can time the excursion. Okay, let me just finish up with the PowerPoint. Okay, so now, if the screen share is loading, make sure we can see it. Can you see the PowerPoint?
Not right now.
It says it's loading. Let me try to stop it and then I'll restart it. Thank you for answering, Justin. Screen share, share.
There we go.
There we go. Okay, good. Okay, so let's go ahead one slide. I'll try to go ahead one slide. Here we go. There we go. If you're interested in learning more about the TScan, which is an incredibly precise and accurate tool, as I think you can see from the discussion that we've been having about what can be seen in just one software feature in the graph alone, how much detail I was able to discern about all those different patients. There's so much in the TScan that is really amazing to learn about. This course is a general TScan use course, TScan and implants, TScan and prosthodontics, TScan and daily practice, with some TScan and TMD. But introduction to TScan is really how you use the TScan, the restorative dentistry, make occlusal diagnoses, handle painful teeth, sore teeth, basically, typical occlusal problems. And the next time we give this course is September 29th. At the Vivos Institute in Denver, and this code TScan23 will save you money on the registration fee. So if you're interested, go to the Vivos Institute website and you can sign up for this course, and we'd love to see you there, Dr. Sutter and myself. The other thing that's very important to pass on to you is if you really want to learn the TScan, your best and fastest way to speed up the learning curve is in-office chairside training with patients, with me guiding you. And this is where you develop real good recording skills. You can see implant patients, prosthodontic patients. You can bring in TMD patients. You can bring in overdentures, splints, doesn't really matter. You're going to learn how to use your TScan in any scenario that would be in your practice. And you learn to do adjustments with high quality TScan data guiding you. You actually learn how to record it, and then you learn how to fix the problems right then and there. And typically people bring in patients that are struggling with their new prosthesis, or they got their teeth capped and they don't like the way their bite feels. And so those kinds of patients are brought in, and the patients are always amazed at like how one session can really improve their bite comfort. And so you learn how to effectively analyze TScan data at the chair, which is what you do when you treat patients. And my role is to guide you and help you through all of these steps. And if you're interested in seeing what doctors have to say about it, you can go to my website, drrobertkerstein.com. And this information is if you would like to talk to me about possibly what is involved in bringing me to your office. My email is here and my phone number is here. But I think it's important that you hear from a dentist. Many dentists have the TScan, but not all want in-office training. Well, listen to this dentist, what he had to say about the difference in-office training made for him.
I kind of thought I knew what I was doing with the TScan, but I was really only using it at its most basic level to guide me a little bit on cases I was struggling with, or post insertion cases, bigger cases, but even then I was just using such a small piece of the equipment. Really didn't know what I was doing until I had you come in and do the in-office piece, and that's where the real learning took place. And then I finally started getting really good results.
And that's pretty typical, that people who have the TScan, they want to get more out of it. And the best way to do that is to have in-office training with patients and having me guide you through the process. So I'm happy to take any questions. Again, we really appreciate your time. I hope I stayed on time, almost 50 minutes instead of 45. So I'm certainly available to take questions. I hope you now can look at this and understand some of the key features. For example, there's excursive friction. There's the patient struggling to close. There's the inability to hold their bite together. They lose force, they squeeze, they lose force, they squeeze. And then, of course, the excursive friction, but they also have posterior teeth involved. Their anterior guidance finally works. That's reading the graph without playing the movie. That's what I hope many of you are able to do after this seminar. So I'm going to stop my share. And Justin, if there are questions, you can say.
Yeah, we definitely have some questions, Dr. Kerstein. Great information. Really appreciate you going through that. Again, to everyone attending this webinar, TScan's a fantastic tool. There's definitely an artistry to this. There's sort of your basic level, but Dr. Kerstein definitely hit the nail on the head. There are much more advanced ways in which to use TScan, and you can get so much more out of a tool like this that can help you in your everyday practice. Dr. Kirsty, we do have a couple of questions. I'm going to kind of go in order for you. First question from an anonymous attendee. Is the wobbly force that you're seeing equivalent to a muscle spasm?
Very good question. It may be, but it may just be muscle weakness being captured by the sensor. A spasm you can see with EMG more clearly. So the inability of the patient to hold the black line stable and the wobbling you see is potentially spasm, but I would say in my experience, it's more likely their muscle weakness. They just can't hold their teeth together and the mandible is wobbling. It's going like this, trying to stay intercuspate. And that's why you see such, many little fluctuations in it. Spasm itself, you can't detect in the black line, but you can with EMG, you can see spasm.
Thank you. Next question for you, doctor. And I think this is in reference to the arch and the percentages. What percentages should there be for anterior, posterior, and canine teeth?
Well, there's no actual real known numbers. So what we try to do is equalize the right and left and have slightly more in back than slightly less in front. So if you think about it logically, you have 6 anterior teeth and you have 8 posterior teeth in a person who has only 28 teeth. So the 6 anterior teeth, theoretically, in closure could make up 40% total, and the back teeth would make up 60% total. And of that 60%, 50% would be on the right posterior teeth and 50% would be on the left posterior teeth, and the same anteriorly. But that doesn't play out that way. It's let's say you have a lower anterior setup where one of the lower front teeth is lingual to all the other lower front teeth. That means there's no contact against an upper front teeth. So you won't have as much force in that quadrant as you will in the quadrant where the lower front teeth line up perfectly well and make contact with the upper front teeth. So the guidelines are 6 to 10% per tooth in the anterior region, 10 to 12% in the premolar region, and 12 to 20% in the molar region are well within reasonable norms for obtaining force distribution. But again, it's not anything that is etched in stone. I think it's more important that if tooth number 3 has 18% force on it, then tooth number 14 should have 18% force on it. And if tooth number 12 has 5% force on it, tooth number 5 should have 6% force on it. So that's how you develop balance, is you have cross arch uniformity to the individual force percentages. But and that can vary too. You can have 2 molars in contact on the left, upper 4, let's say, on the left, and only 3 make contact on the right. One of the lower molars is out of contact. You can't get perfect balance when the teeth don't line up exactly right. So try to use those numbers as a guideline: 6 to 10% for anterior teeth, 10 to 12 for premolars, and 12 to 20 for molars.
Great info right there that everyone should definitely take note of. Next question for you, doctor. Someone complimented you, wonderful presentation, but the question is, do you integrate the intraoral scan in all of your patient? If not, what's sort of your case selection when integrating an intraoral scanner?
The answer is, if I have an intraoral scan to integrate, I'll integrate it. And because it makes it simpler to match the data to the locations on the teeth for the doctor, meaning it's easier to see if you match the data well that this, pink or this red is on the mesial marginal ridge of tooth number 14. You know exactly where to go look for that paper mark. You still have to mark the teeth, but the intraoral scan really shows you the locations really well. Having said that, it's important for a TScan user to be able to use the generic TScan arch and not use the STL scan, to be able to manipulate the generic TScan arch, to be good at using the generic TScan arch, to set up the TScan arch well, because you may not have access to an STL file. And so you're going to be able to still use your TScan with the generic arch if you understand how to manipulate that ideally. And of course, that's something that we teach you in training, and it's essential. And in most of my PowerPoints, all the arches are set up exactly right. I really rarely present faulty arches, bad arch design, because it doesn't help the doctors learn, and it doesn't help them at the chair. If you don't take out the missing teeth, if you don't figure out the arch dimensions correctly, if you don't with, close the arch if teeth are missing for orthodontics, you're never going to be able to find the right context to adjust. Your TScan arch won't match the patient. So to summarize, it's great to have the STL file, and I use it as much as I can, but all new users have to learn to use the TScan generic arch appropriately to be effective with the TScan.
Agreed. The next one, we will be sharing this recording, but next question we have is, what's your opinion on using TScan when, I guess, adjusting when in orthotic?
Oh, it's great to use TScan to adjust an orthotic. There's no area that you would be adjusting anything that doesn't benefit from having TScan metrics, force and timing parameters, balance parameters, right to left, imbalance parameters, all of those things. You get a much better splint outcome in anything that you do. So for example, since you asked about a splint, let's say you have a patient that has a bad left TM joint and you're opening their bite to unload that TM joint, but you give them a splint that's 75% left, 25% right. That's not going to help that left joint, even though you open the bite. But you don't know that when you make a splint. And one of the misbeliefs that we all have, or we've been taught, I can't say we all have it, but we've been taught, is that if you make all the marks look the same, you've balanced the bite. That is completely untrue. All you've done by making the marks look the same, for example, on a splint, is make the marks the same size. You have nothing to do with forces and timing and balance and optimal outcomes. So only with the TScan measuring this information can you know that that bad joint doesn't have a 75% splint side banging into it, right? We'd want it to be maybe 55% on the right side on that case and 45% on the left side where there's a bad joint. And that's how you can control your outcomes much better if you have TScan data. So absolutely with splints, it's a major advantage to you and to the patient to use the TScan with splints.
Okay. Have someone asked two different questions. I'm going to tackle them. I'm going to throw them at you both at the same time because it looks like they're the same, kind of question. What should the final outcome of selective grinding? How much force should each tooth receive in maximum intercuspation? And what are the rules for selective grinding?
It's too broad a question to answer without case examples. So the objectives with the TScan, just to summarize, are exactly what you saw in that one case with that young lady with all the recession and abfraction. Short occlusion time with good balance, center of force in the middle of the arch, enclosure, rapid disclusion in less than 0.4 seconds in all directions with the anterior guidance quadrant taking over right away with the graph lines looking specifically corrected. That's what you're seeking in any case that you treat. Those two parameters, I can show that to you so it's more viable. I actually can show it in the PowerPoint because it's easier to do that. So let me just, if I find the slide, yeah, right here, this slide. And let's hit resume slideshow. Whoops, sorry, let me go back. I'll go back. Okay, it's coming here. Right here, right? You want to see the center of force come down the middle. This is the closure center of force. So the patient's biting down. This is the A to B period. Then in the C to D period, you want to see the center of force go straight to the canine. You want to see a sharp rising black line in A to B. You want to see the patient be able to hold their teeth together well, whereas you can see, what's interesting about this patient is, even though she has a couple of hitches, she actually has less of a decline in postoperatively than preoperatively. She has more of an arc and a waver than she does when her bite is improved. Here she has a little bit of wavering, which is no question similar to this, but then she really holds her bite together really well. This is after treating her. That's what I mean about this is how you use the data to show that you made a difference. And then, of course, the excursion, you see how the red line takes over and the orange and blue lines drop. These are the things you're looking for as outcome measures. What does the center of force do? Where does it travel to? What do the graph lines look like? It's not the percentages on the teeth. You can try to make those perfect, but unless you correct the closure parameters and the excursive parameters, you won't get the outcomes that we're able to get with the TScan. So there's timing and force parameter outcomes that are more important than did you match tooth number 3's force percentage to tooth number 14's force percentage. It's not, that's not as critical. And you can envision that. Let's say I had perfectly aligned teeth except for tooth number 5. Tooth number 5 was turned 30 degrees sideways. Well, it's not going to match tooth number 12 because it doesn't touch the opposing premolar the same as tooth number 12 does, touch its opposing premolar. And so you can't match the forces up then exactly. So it's better to learn how to use the T-scan to control the entire environment rather than to try to match each tooth to a specific force percentage.
Okay. How does bite force capability affect the T-scan?
Well, that's a good question. I'm not sure the question is posed correctly, and that's not a criticism. Bite force capability is recorded by the T-scan. So if someone has a really good bite force and good strength, the T-scan will capture it, but you need low sensitivity for them. As you run into people that have bite force weakness, muscle tension, TMD symptoms, you have to customize the sensitivity to match their capability, and that's how you get really good data. So the T-scan is not affected by bite force. The T-scan records the bite force, and your ability to customize the sensor to match the patient is a crucial part of that. And again, those are skills you have to learn either through training or through learning online or taking courses.
Okay. What articulating paper do you like to match the T-scan data with?
So the best match is with Accufilm 23 micron. It's the carbon paper that's been shown to give the least number of false positive ink spots, which is really important when you work with the T-scan. You don't want any extra ink that messes up what you're trying to see on the teeth. And it doesn't leave false positives. I should say it leaves the least number of false positives. So that means it doesn't mark where there isn't contact. And once you get above, once you get above 20 microns, 60, 70 microns and higher, you get a lot of false positives, and that's been researched. So 20 microns would be great, 12 microns would be great as long as it marks well. Some of the 12 micron foils don't mark so well, but Accufilm pairs with T-scan very well.
Okay. I'm going to get to the last one because we're kind of approaching an hour.
Okay.
I'm going to get to one more question, but post debonding, would you wait for a few months before you use the T-scan, as the teeth may not have settled completely?
That's a very good question. So what we found with orthodontic studies on settling and T-scan is that the teeth don't settle. And what I mean by that is they settle, but they don't balance. It's not like an accordion and they push each other into perfect balance. Actually, they rarely do that. And most of the time they settle in a very bad orientation, usually plus or minus 10% from 50 or greater, meaning 60-40, 65-35. You don't get these. The belief system in orthodontics is that the teeth are loose, so they push each other around and you get balance. It doesn't happen. There are multiple T-scan studies that show that. So using the T-scan at debonding to clean up the A to B period and the C to D period enhances settling, because you actually get the patient into a close to balanced bite in A to B, and then you disclude them in C to D so that they don't push their teeth around and raise muscle activity levels. And then the settling is actually very effective. So it's much better to use the T-scan close to debonding than to wait months and months for the teeth to harden up in a bad orientation.
Okay. Well, I think that's going to be it for now. Dr. Kirstein, thank you again. Great presentation for everyone that has attended. If you're, Dr. Kirstein put the information up. If you're interested, I would highly recommend reaching out to Dr. Kirstein, talking about, possibly bringing him in for an in-office visit, really taking your understanding and the use of T-scan to that next level.
Yes, and thank you everyone for attending. I really appreciate you taking the time to learn. There's a lot in the T-scan that will help you do much better occlusion, much better prosthetic insertions, much more control over your implants. You just need to learn how to use it really well. So thank you for taking the time to start to look at the graph as an important part of that process.
All right. Everyone have a good day, good evening, good night, wherever you may be, and thank you for attending.
Yes, thank you all.